Great. Okay, well, welcome everyone. Got an exciting presentation today from Dr. Christine Cassidy and Dr. Marie Somerville. And I'm just going to turn it right over to you, and we look forward to listening and having a great discussion after.
Great. Thank you so much, everyone, for attending this presentation today. So I'll first introduce myself and then pass it to Christine to introduce herself, and then I'll get started with the presentation. So my name is Marie Somerville. I'm a postdoctoral fellow and a health system impact fellow at IWK Health and Dalhousie University here in Halifax, Nova Scotia. And Christine, I'll let you introduce yourself.
Sure. Hi, everyone. I'm Christine Cassidy, and I'm an assistant professor in the School of Nursing here at Dal, and also a scientist at IWK Health. And I have the pleasure of co-supervising Marie with a great team, including Dr. Janet Curran, Dr. Doug St. Clair from the IWK, as well as Dr. Annette Elliott-Rose.
And today we will be co-presenting on our program of research, which is looking at how we can transition to a learning health system. And we're going to share with you our proposal for implementation research. So we'll first go through a bit of a background on what learning health systems are. So what are they defined as? What are the goals of learning health systems? What are some learning health system frameworks and characteristics? And then we'll share with you some of our research on this topic of learning health systems and talk about some of the gaps in the research that we've found, and then how we're going to address these gaps in our future research. So learning health systems were initially defined in 2007 by the Institute of Medicine as a system where science, informatics, incentives, sorry, I'm just gonna close my little Zoom window here, okay. Where science, informatics, incentives, and culture are aligned for continuous improvement and innovation, with best practices embedded in that delivery process with new knowledge captured as a byproduct. More recently, in 2012, the Agency for Healthcare Research and Quality kind of expanded on this definition, and they define learning health systems in which internal data and experience are systematically integrated with external evidence, and this knowledge is put into practice. So as a result, patients get higher quality, safer, more efficient care, and healthcare organizations are better places to work. So essentially, learning health systems are health systems that are continuously trying to bring evidence and data into practice. And across the literature, there's many different terms that are used for learning health systems. So you might see learning health system or learning health care system, learning health networks, rapid learning system, or rapid learning healthcare. So this term is new. Learning health systems is a fairly new concept. But they're essentially all talking about the same thing, and this idea of continuously integrating evidence and knowledge into practice. And for our presentation today, we'll be using the term learning health system, or LHS for short. So learning health systems can also come in many shapes and sizes. So for example, in Switzerland, the Swiss learning health system is a nationwide learning health system. Similarly, Evidence Now is an example of a learning health system in primary care settings across the United States. That's also a national level learning health system. Whereas in British Columbia, they're working towards a provincial learning health system, or a learning health system could be at a smaller level. So the Learn from Every Patient, or the LEAP, is an example of a learning health system, which was specifically designed for a cerebral palsy clinic. So it's at the clinic level. And really the goal of learning health systems is to enhance value-based healthcare. So this means improving patient outcomes, reducing costs, providing better value care, generating knowledge, and optimizing that knowledge and evidence for decision-making in practice. And I just included this model here on the right from the Agency for Healthcare Research and Quality, because I think it's a really good visualization of what a learning health system is. So it's this cyclical manner of bringing research and evidence and data into practice. But at the center, it's the patients and the healthcare providers that are using that evidence that we're creating, but they're also creating new evidence in terms of patient experience and provider experience and clinical outcomes that are also being put back into the system as forms of data and evidence. There's also several different learning health system frameworks out there. Some are focused more on sort of what the concepts of a learning health system is, whereas others are focused more on how do we operationalize a learning health system. So on the left, this framework is by Manier and others. So this is from a Canadian health system researcher, and they propose that a learning health system kind of starts with these core values and pillars which support the learning health system processes. So that process of bringing data and evidence and knowledge into practice, which then influences the learning health system outcomes. So patient experience, population health, healthcare costs, and provider experience. In the middle, this is an example from the Learning Healthcare Project. So this is a framework where you can see that kind of core idea of learning health systems in the middle, so that cyclical process of bringing practice and evidence data into practice. But then they also expand to show that if you're going to operationalize a learning health system, you need to consider some certain components. So knowing that a learning health system is complex, you need to consider these factors of complexity. And also thinking about strategic priorities. So how are you going to implement a learning health system? What kind of behaviors do you need to change in order to bring that learning health system to life? And then the outer circle showcases the rationale for a learning health system. So why are you implementing a learning health system? What are those kind of outcomes that you're looking for? And then the third example here is from an Australian group, and they propose that a learning health system is really focused on these 4 key pieces of evidence. So evidence in the form of stakeholder or patient engagement, evidence from research, evidence from data, and implementation evidence. So these 4 pieces of evidence are important for operationalizing a learning health system. So I'll pass it back to Christine.
Great, thanks, Mari. So this slide here really just takes those big concepts of a learning health system and the models and frameworks that Mari just explained and distills it down to 4 key components with about 7 characteristics. And so this builds on John Levis's work and his team from McMaster. So learning health systems are data and evidence driven. So they're always bringing in health system, patient experience data, as well as research evidence to inform decision-making. Learning health systems are also patient-centered, with engaging patients and communities at the core of everything that they do. It also needs to be supported by the system. So we need to have aligned governance, financial arrangements, as well as how care and services are delivered to actually support this concept of a learning health system. In addition, it needs to have some appropriate decision support. So dashboards, data, managerial reports, all of those decision supports to actually help inform appropriate decision-making. And lastly, in order to have this rapid cycle of learning and improvement that Mari has explained, we need to have the culture and the competencies to support that work. So if we go to the next slide, a lot of what we've explained so far is really theoretical conceptualizations of a learning health system. And a lot of the literature really dives into this theoretical component, but few healthcare organizations have really described in the literature, what does this look like in practice? How do we actually design and implement the different components of a learning health system and then evaluate its impact to see if it's impacting patient, provider, health system, population, health outcomes. So we're going to go through a bit of a case study on how we used a learning health system framework to study COVID-19 rapid response, as well as planning at the IWK, at IWK Health. So just to situate all of us, I'm sure it's not too hard for everyone to kind of put themselves back to where they were in March 2020, when we were hearing about this coronavirus, which soon then became a global pandemic. And we were seeing a range of health system interventions that were being quickly designed and implemented, while these significant restrictions were being placed on our social and our health systems. So there was a rapid change happening to a system that we know has traditionally been very slow to transform. So as researchers, we saw this as a great opportunity to explore how health systems adapt under this rapid and constant change. So the next slide just outlines the purpose of this study, which was really building on that concept of learning health systems. We wanted to use a learning health system lens as a way to identify assets and gaps in health system pandemic planning. This was a pretty big project, and this research presentation specifically is going to focus on the data triangulation aspect, where we map study findings onto a learning health system framework to really understand those assets and gaps. So the larger study used a concurrent triangulation mixed methods research design, and we conducted qualitative interviews, semi-structured interviews with patients and families, healthcare providers, members of the leadership and management team at IWK Health, as well as operations and support workers. The quantitative strand of data included administrative and textual sources, such as relevant organizational documents, system performance data, anything that was generated between January 2020 and the end of August 2020. So we were really looking at that early stage of the pandemic. I'm sure at the time when we were doing this, we did not expect to still be in the pandemic presenting it now in May 2022. But the focus of this setting was at IWK Health, so the tertiary health center serving children, women, and youth in the Maritimes. And this was guided by an integrated knowledge translation approach. So our research team was led by Dr. Janet Curran, and we had a team of clinicians, managers, and researchers and administrators that met bi-weekly throughout the project, really to discuss project milestones, what were the preliminary impressions and interpretation of the findings, as well as some of the gaps in our data collection and analysis. So the next slide shows how we dove into the data triangulation. So we used a data triangulation protocol, which maps the quantitative, so the textual administrative sources, and the qualitative semi-structured interview findings onto the 7 characteristics of a learning health system. And so we had 2 independent team members categorize the quantitative and qualitative findings into the corresponding cells of this table to identify health system supports and research supports as it relates to each of the learning health system characteristics. So the next slide, the next 2 slides really highlight those assets and gaps of pandemic planning according to the 7 characteristics of a learning health system. So you'll notice the red and green slide at the bottom just is my attempt to show how well the health center did in these areas. So green represents assets and red represents gaps. So what I want to highlight here is that there was a significant shift early on in the pandemic in an organization that has been known to be very family and patient-centered care. That is the core of the IWK Health philosophy. But right from the get-go, with so many restrictions coming in, patients and families weren't necessarily engaged in those decisions early on. Also, when the pandemic started, our findings identified limited formal linkages, so a formal linkage between and within the healthcare community and the research community for that timely sharing of research evidence within this organization to really support that policy and practice change. So that co-production, co-design approach wasn't leveraged in that timely way to address some of those big health system problems that were happening. The next slide shows the final 3 learning health system characteristics. And we found here that teams worked really quickly from a governance perspective to actually shift a huge proportion of their workforce to actually working from home. The teams also worked very closely with unions to facilitate this rapid staffing changes and reemployment that was brought about by the pandemic response. And from a culture and competencies perspective, everybody really had to jump on board because there was this common goal, this unified objective among everybody to curb the spread of the virus. And that was very early, that was there from early stages of the pandemic. It's important to remember with these findings, it is in that kind of March to August 2020 when the data was collected. And so this really was, I think, before that real COVID fatigue hit, when everyone was still on board with that unified objective. So the next slide, just want to highlight some key takeaways from this case study and from this work. Starting off with the importance of engaging patients in this decision-making. So many of the usual ways of working that were based upon patient and family-centered care principles were limited during that early phase of the pandemic planning and response. And we know that just restrictions on family presence within the building doesn't necessarily replace the principles of family-centered care. And so the health center really kind of learned from that from the get-go, and moving forward had started to engage public and patients with some of these decision makings around COVID-19 restrictions and using innovative ways, which we now all know very well, as Zoom, Teams, things like that, to actually bring in that patient and family voice. In terms of data capture, linkage, and sharing, the organization did the best with what they had, given that they don't have an electronic health record. And so from the literature, we know that a learning health system, which really is all focused on bringing in that real-time patient experience data, research evidence, clinical data, and it's hard to actualize and fully realize a learning health system without that adequate digital capture of the care experience. And so we really need to start to build that digital infrastructure that includes care experience data, process outcome indicators to inform that rapid cycle of policy and care delivery decisions. And so this study highlighted the existing health system research structures and partnerships that support the timely inclusion of evidence into decision-making, and that they weren't necessarily well established from the get-go. And in order to be most effective in supporting the learning health systems, researchers that are fully integrated into internal environments where those health problems are identified, priorities and plans are set, new initiatives are developed and launched, that's where we start to see a learning health system. So having that academic and health system partnership is so critical, which is what is so valuable about the health system impact fellows like Mari, who are able to actually identify problems in real time and start to generate and embed evidence in there. I think the last piece that this study shows is that the organization was already implementing many features of a learning health system pre-pandemic. And they had the capacity and the infrastructure to really further this concept of a learning health system without completely altering the way that it works. And so the COVID-19 pandemic really has helped the health center to start to be more of a functioning learning health system by identifying what those assets and gaps are. It also, moving forward, has shown ways that we can design, implement, and evaluate learning health systems, promote the rapid integration of all of that evidence, the lessons learned from patient experience into our decision making. The next slide just goes to show that that's a pretty big pie in the sky idea. So how do we actually do that? And that's what I'm going to hand it over to Mari to explain some of the research we're doing on that question.
Sure. So following on from what Christine was talking about what we learned from our case study here at the IWK, and how to kind of start transitioning to a learning health system, what some of those assets and gaps were during COVID. How can we use that to kind of build on this evidence and really fully make IWK a learning health system? So part of my work as a health system impact fellow and being embedded in the IWK, I'm just going to share with you some of my proposed research, which is the kind of starting point for moving the IWK towards a learning health system. So in the first phase of my work, I'm conducting a systematic review with Christine and my other supervisors. And the aim of this review is to identify and synthesize the evidence related to learning health systems and implementation across different healthcare settings. So we're looking for any types of research articles, so quantitative, qualitative, or mixed method studies that include that learning health system concept and include some aspect of implementation or evaluation of learning health systems. So we are now in the data extraction and synthesis phase. So I can share with you some of the preliminary findings from this work. And what we have is so far 25 studies have been included, and most have been published in the last 3 to 5 years. So the majority are from 2019 till now. So that just goes to show how new this area of research is and how this learning health system concept is really building traction. And it's kind of, yeah, it's a very important area of research, and there's a lot of interest in it. And then we're using the ERIC taxonomy of implementation strategies to code what implementation strategies were used across these 25 studies to see sort of how are people implementing a learning health system and how can we use this information to then help other people transition to a learning health system or have other organizations. So some of the more common strategies that we've identified so far include things like changing record systems, which makes sense because as a learning health system, you're trying to bring data and evidence into practice. So changing the record system to be an electronic record system, for example, is really important to allow that health system to bring that data and evidence into practice. Some other strategies that we've noticed that are quite common are building a coalition and using audit and feedback data. Building on that first phase of work with the systematic review, the next phase of research is to evaluate the patient safety program here at the IWK. So the patient safety program is a center-wide program where they monitor any safety events that took place during that week. Safety consultants meet and kind of work to address any serious safety events or moderate level safety events to kind of prevent future events from happening or implement interventions to address any safety events that took place. So we first want to understand and evaluate the current patient safety program in terms of a learning health system. So we want to understand how are patients engaged? How is evidence used to inform practice in the patient safety program? How does the culture of the IWK or of the safety program either support or inhibit patient safety? And then how do system structures support or inhibit the patient safety program? So drawing on those 4 key features of a learning health system, we're trying to understand what is the patient safety program in its current state, and how does that map to the idea of a learning health system? And then building on that, we want to implement a patient safety intervention. So depending on how we, or what the data is from that evaluation, we then want to kind of pick apart each of these learning health system features and focus in to really make sure that the patient safety program is patient-centered and is using data to inform their practice, and then sort of moved through each of these learning health system features to slowly create a patient safety program that really meets this concept of a learning health system. And then from this, we can maybe build on that further across the organization to different units, different departments, or different hospitals across Nova Scotia.
So what Mari has described here is how we are really studying learning health systems and the science behind learning health systems with our team. So, building on that review and actually identifying what is the evidence around implementing a learning health system and actually trying to transition, whether it's kind of micro teams, a unit, an organization, a broader system to be continuously learning and integrating evidence into practice. So there's different kind of components that we want to study to better understand that. For instance, how are we supposed to be engaging, and how do we best engage patients in this concept of a learning health system? We, over the past number of years, have gotten really good at engaging patients in research, but how do we then take it a step further and actually engage patients in this idea of learning health systems from an organizational or a community health system perspective? Building on that, using those scientific methods to design, implement, and evaluate interventions that actually support the adoption of a learning health system, as Mari described with the patient safety program as an example. And of course, it's one thing to implement an intervention, but we want to make sure that these learning health systems are sustainable over time, so that continuous rapid cycle of improvement doesn't just happen once, but it is supported and maintained over time. Of course, if you click on the next slide for me, Mari, developing, learning health system science evidence is important, but it's really important to always be linking that back to the practice of learning health systems. So how do we actually do this in practice? And this is a key focus of the Maritime SPORE Support Unit. So they have a learning health system working group that Mari and I are a part of, where the goal of that and the aim of it is really to facilitate the adoption of learning health systems across the Maritimes. And there are some areas in the Maritimes that are doing this really well. There's teams within the IWK, there's teams at Nova Scotia Health. I know there's teams at Vitalité in New Brunswick, where they're called clinical learning units, where they're actually building this concept of a learning health system and doing it in practice. So part of our work through the MSSU is to actually identify some of these areas where things are going really well. How can we learn from it and actually try to facilitate that and spread it across the Maritimes to different areas, different systems. So part of that will be actually to develop a mechanism where we can identify patient, community, health system priorities that align and could be used in a learning health system. And developing some type of toolkit, adapting what we know that's working really well in these areas in the Maritimes to actually support the adoption of learning health system practices in other areas. So that's how we see us kind of bridging this learning health system science and learning health system practice gap as we move forward with some of this work. And I think that is it. Perfect. So thanks everybody for listening, and we'd love to hear your thoughts, especially because we're in the early stages of this work and just getting going.
Great. Thank you so much. What a fantastic presentation. So much information to think about. So just going to open it up to the audience for discussion. Go ahead, Marilyn.
Yeah, hi. Thanks so much, Christine and Mari. I commend you for the timeliness and the getting this study done. So, well, actually in real time. And then as I looked at the results, what really struck me was, as you pointed out, is that level of engagement. And so that's what one of the things you're going to go after is how to engage people, because clearly when the pandemic was declared, there were individuals and or groups that came together and made decisions. And so it appears that patients and families aren't part of those individuals or groups. And it'll be interesting as you continue with your research and do the evaluation to see how that plays out.
Yeah, absolutely. And I think that, oh, sorry, Mari, go ahead.
I just said thank you. That's it.
I was just going to say, Marilyn, it's a really good point. I think that's what's interesting about this research is that it's from, the very early stages, that first wave of the pandemic. And so in a true learning health system fashion, the team has been able to learn from the study that studied the learning health system itself. And now, we should be strengthening our partnerships with researchers, bringing patients into all of those conversations. So it's not just about, their physical presence within the building, but how are they at those tables where those decisions are made?
Yeah, and certainly as you know, long-term care and home care and all that is a focus for me.
Mhm.
And, I'm sure, well, it's clear from the, when visitation stopped, the incredible impact that had. When, had that consultation been, that is part of a learning health system, had it been present and real in terms of organizations, it would have made for, I believe, a very different path for individuals.
Absolutely. Thanks, Marilyn.
Yeah, go ahead, Logan.
Christine and Mary, that was a really timely presentation, as I'm sure a few people have pointed out. I'm curious, you've used COVID-19 as kind of your a case study. And I think that COVID-19 is a really interesting choice because in a lot of ways, like it doesn't reflect the typical reality of how a health system functions, right? Like we had a single problem that everyone agreed was a problem. We rallied behind it. We did some amazing things. But now we face the challenge of moving back to a world where we don't have a single problem. We have, a few $1 billion for a healthcare budget. It could be spent a bunch of different ways. And there's often negotiation and other strategies, I guess, that are used to figure out, what do we spend our finite resources, both financial and just like attentional resources on. So I'm curious, I guess, to hear your thoughts on what you've learned by studying COVID in the context of a learning health system might be different when we look at other problems that health systems have to try to solve.
Mary, do you want to take that one first, or?
Sure, I guess I can just talk about that in terms of my next phase of work with the patient safety program. And I think one thing, so it's very early on, and I do think it will be really interesting to see how it plays out in a non-COVID related topic. Like patient safety has always been an issue. It's going to be an issue, whether COVID is here or not. So I think one thing that I've noticed though is having just like that core group of people in the leadership who are standing behind this as an issue. So with patient safety, there's a large group of like leaders in the healthcare organization who really see that as an important issue to tackle. So I think kind of taking their lead and having the health system identify what they want to focus on. And then as a researcher coming in and supporting that to build that as a learning health system. And hopefully we can show that this idea of a learning health system leads to benefits and positive patient outcomes. And then maybe we can build off of that and apply it to other areas. But I agree, I think it will be very interesting to see like a different example of a learning health system.
Yeah, and I just building on Mari's comments, you're right, Logan, it's very different. But I think that as Mari mentioned earlier on in her slides, this is such a newer concept. I think most of the paper is 3 to 5 years, correct, Mari? So even when we started out with this work, we were struggling to conceptualize, okay, what is a learning health system? Does it have to be the entire like Canadian healthcare system? And so using COVID as a case study example is actually a little bit easier just to kind of map out what are the assets and gaps. And then in the end, it showed us that it doesn't need to be a project or a topic that every single person's on board for. Yes, that might leverage the culture and the competencies characteristics, but then how can we now know those assets and gaps and use it in smaller teams like Mari's patient safety program example, or maybe departments or clinical units within an organization, within a community. And I think that what we've learned from the assets and gaps can then be used in these smaller areas and doesn't need to be an entire organization that everybody's on board with, like it was with COVID. I think the other thing that's from the review that Mari's leading is a lot of those examples, those aren't COVID examples, they're other learning health systems. So actually drawing on what we're learning from those and comparing them to our COVID case study findings will be interesting to see the differences there as well. But thanks for your question.
Thanks to you both.
And you can see the chat, Christine and Mari.
Oh, yes. What role do we see for the private sector in developing or supporting or maintaining a learning health system in Nova Scotia? That's an interesting question. I guess, I don't know how I'd answer that, but firstly, what comes to mind is kind of business. And I'm sure businesses rely on similar frameworks as a learning health system, like trying to use data to influence change, and social media and things like that come to mind. But maybe I'll let Christine answer this question.
Yeah, I know you're definitely on the same track that I'm thinking, Mari, and Tim, if you have like specific private sector examples, would love to hear them. But I'm even thinking from a data perspective, there's such a focus with learning health systems on data, and is the role of industry partners within the private sector to help us with that data piece, being able, it's all about that timely capture of data, not just capturing it, but how do we actually link it and share it to inform decision making. So I think I could see that being a really important component of the private sector that could be used in a learning health system.
Yes, if anyone would like to type anything into the chat, comments or questions, or just shout out, turn your mic on. We would love to hear from you and see you. Logan has a question.
Well, no,
Go ahead.
I want to call Tim out because, like, I mean, he has this great perspective having worked in the private sector in like a health related capacity. So yeah, and it's so often missing from most of our discussions around health system.
Is my microphone working? Can you hear me?
Yeah.
All right. Yeah, so I was thinking, I mean, there's a few different ways I could see this coming in. I mean, I work in consulting. I mean, I think we just have like a lot of expertise that exists outside of like the academic and public workforce. And so I think there's definitely a way to tap into that. And it's people who are doing things that are maybe slightly different. And like maybe that's on the analysis side, maybe that's on the like setting up the structure, maybe it's on like some of the strategic advice that people in the industry might provide. But I also think of like in the US, for all the woes of their healthcare system, they do have some interesting work going on with like, you have a private sector team who collaborates with and maintains these huge data sets of patient data, and then works with clinicians to answer like specific questions about like patients in their center. And so it's kind of like the private sector becomes part of what we use like our academic groups for right now. So just more integrated in like ownership of the data, working with the data, like that piece of it. I think I see some of that as well in like Alberta with some of their oncology health data sets. They're actually like some of the stewards are private consulting companies. And so they work a lot with industry, and they also work with academia, and they kind of protect access to and guide people through the use of some of the administrative data sources in Alberta.
That's really helpful. And I feel like, Mari, with the review, part of our synthesis will be interesting to see where some of these, because a lot of the papers, Tim, are from the US. So are they industry partners, they private sector? And I think that would be an interesting discussion point for the review that could inform then how we transform learning health systems moving forward. So thanks for sharing those insights.
I do also think, just as you're chatting there, that like the opportunity, I think, for private to kind of speed up the process. I know healthcare is so political, and sometimes things take so long. And I wonder if working with private sector industry can kind of help speed up that process and actually fully create that rapid learning health system.
Great. Anyone else? Or Christine and Marie, if there's anything else you would like to add that you'd like to say.
I think we said it all, did we, Mari?
I think so. A great turnout, though. I'm really.
I know, it's so nice to
nice
see everyone.
Yeah.
Can I ask a follow-up question?
Yeah.
So, it's interesting when you're doing like kind of a case study, you have to bound it. So you look specifically at the IWK, but the IWK is just, one partner within that. I know early on, Christine, you said, the learning health system, does it have to be all of Canada, or like, how do you kind of bound that? So I'm curious to hear, I guess, like, how do you think, given that stakeholder engagement and partnership seems to be one of the pillars of a learning health system, do you have any kind of thoughts on like how that looks? How's Nova Scotia's kind of assets in that capacity beyond just the IWK?
Yeah, and that kind of last slide that we had there with, the science and the practice. And so the science in this case that we explained was looking at the IWK and generating some learning health system evidence around that. But as part of the practice, through the Maritime Sport Support Unit, we have this working group where we have representatives from, health organizations and communities from New Brunswick, PEI, Nova Scotia, so IWK, Nova Scotia Health, that are all either doing really good learning health system work in different areas or want to be doing more learning health system work. And so that's been an opportunity as we move forward. We're just kind of getting that. We actually just had our 2-day retreat over the past 2 days to map out the work plan for the next 2 years, but building on what's working really well within the province, within the Maritimes, and developing those linkages and partnerships, then we can move it forward to other areas where maybe they've had barriers to becoming a learning health system, or they've been trying it over and over again, but they can't. So I think that's part of it, is seeing the assets within the Maritimes and then moving it forward from there from a learning health system practice perspective.
Interesting. I like where you're thinking, where it's beyond Nova Scotia, and it's like, how do we learn from each other and put it in practice? Because
that's the thing. And I think, I said that earlier, that even when I first started learning about this concept, I really thought it was this big, like, had to be the entire province or the entire country. But no, like a learning health system can be on a specific unit even. It can be in an entire organization. And so it's just learning from patient experience, learning from research evidence, and integrating it into what we're doing.
Cool. I think Nova Scotia is lucky to have you two on the case.
Thanks, Logan.
Mari, I
just saw a question. How did you build the program evaluation for the safety program?
Yeah, I just wanted to say this was an amazing presentation and great work on the systematic review. And I really like your application of the learning health systems approach and the different components. I'm just curious about the program evaluation piece. And is it an impact evaluation or process evaluation? Can you describe that further, please?
Thank you. And this is a very, early stage of that evaluation piece. So we haven't fully mapped out how we're going to do that, but we envision, similar to how we did with the COVID work, is kind of drawing on like document analysis and interviews to just understand what's happening and how does it map to that idea of a learning health system. But Fidi, I know you have a lot of expertise in evaluation as well. So because we're at the early stages, if you had any thoughts on that, I'd love to hear your insight, but it is very kind of like planning stages right now.
Parts of my scoping review have provided patient safety related evaluations, specifically in the hospice setting, as well as more general theoretical frameworks focused on program evaluations that are available through the Canadian Evaluation Society, Mari. So I'll forward them your way by email, and it could help support some of your research.
Great, thank you.
I have another question if you have time. I'm wondering, do you find, I might have missed this because I did join a little bit late, I'm sorry, but did you find there's like the actual term itself, I guess what am I trying to ask? Like just whether it's going by different names, and whether that's coming in as well, because like it does sound somewhat familiar to like there's like this kind of it's called like the green button from Stanford Health, and it was a little research program that then like spun off into a company that was about like point of care. It was like that vision of the physician standing there looking at the data from the day before and then coming up with like the plan they were going to do for that day for a given patient or something like that. Just whether you saw like the same kind of concepts being used with varying terminology.
I do. So I know that is a challenge with this work because there are so many different terms like rapid learning health system, learning health network. And so that was something that we really had to figure out when we were doing the review was, do we want to include studies that talk about those concepts of a learning health system, like data-driven and patient engagement, or do we want to just stick to that? They have to say learning health system in some shape or form. And we went with the latter. So we only stuck with papers that use that learning health system terminology. So, I mean, a limitation of that is that maybe we are missing true learning health system studies because they've spoken about it with those key concepts of a learning health system without calling it a learning health system. And I think that's kind of a challenge of it being a new area of research as well. And I don't think there is just one term that everyone uses. Even across Canada, people use different terms. So yeah, I think that's a challenge, but I see the best way is just kind of trying to stick to those really specific terminology like learning health system or learning healthcare system.
Yeah, like I think there's probably 4 or 5, Mari, that you used for the review that they had to say, but in classic supervisor fashion, we wanted Mari to finish her review in 2 years during her fellowship. So she couldn't go find all the green button programs, Tim. And we wanted this to work to inform her second year of the fellowship, right? So she's just in year 1, then be able to use it with the patient safety program. So a feasibility perspective on the review as well.
I understand the need to be pragmatic, don't worry.
So can I just ask a quick question? I'm sorry, I'm driving, so it might be a lot of background noise, but just to build a little bit on Tim's question, if someone's so old school, you're coming to try to describe the health system's learning, and people say, okay, so we've been doing evidence to practice, implementation science, patient-oriented engagement to increase knowledge update, quality improvement using continuous data to be able to inform practice. How would you situate all those sort of previous philosophies or system-driven type of initiatives or overviews sort of within? How would you separate them or put it within a health systems? If someone said, so what's really different? Or how do they overlap if they do? Or
it's a really good question, Marcia. And it makes me wonder if this happens with like every area of research that just over the years, CIHR decides to call something new, and so then everybody jumps on this bandwagon of it needing to be termed this, but really it just means KT, implementation science, patient-oriented research, everything that you just described. And so I do see those as kind of all within a learning health system, but maybe a learning health system is more of this umbrella term that brings all of the different pieces together into one structure. So having the data there, it's not just about implementing evidence, but actually generating the evidence and with partnerships, with patients, with communities, with clinicians, with administrators. So I almost see it as just all the things we've been working on all these years, but put into one slide, maybe. That's a very non-academic way of describing it. But yeah, I don't know, Mari, that's how I've been trying to conceptualize it in my own head as someone who was trained as an implementation scientist who now is navigating the learning health system lingo.
Yeah, I would agree with you. It's a complex area, I think, and I do see it as kind of like overarching that brings all of those pieces in together.
And it kind of makes it less daunting, I think, when you think of it like that. Like when I first heard it, I was like, oh my, we're never going to get to be a learning health system. And then it's like, oh wait, we are doing some of this work. This isn't brand new. It's just how do we put all the puzzle pieces together so that it's more of a continuous cycle. And it's not just this start and stop of a implementation researcher coming in, implementing an evidence-based practice, and then out the door to try and get the next grant, right? I think it's more about sustainability, scale and spread and things like that. And then also, I guess, capacity building within an organization, within the health system.
Yeah, I agree. I think like when I was listening to you and I've been doing previous reading on it, I think a couple things that you mentioned. I do think that it's a reinvention of what we've been trying to do for 30 years of just making sure patients and families get the best, most evidence-based care, and that we learn from how we do with provision of that care to inform future care.
Exactly. Yeah.
But I wonder if it's almost like if you think about, you know, the trend for a long time was then, you know, it was very healthcare provider focused, clinician led. Then there was the patient oriented, patient engagement stream. And still we didn't see the outcomes or the change that we had hoped for. And so now I wonder if it's not just a sort of renaming and refocus it as a health, like a business model and a more institution or like higher level change model that people are thinking, okay, yeah, now if it comes from the institution or, you know, business model, maybe we'll actually get the change that we want. I don't know if that's it, but
instead of it kind of being situated with the researcher, I'm doing patient-oriented research, it's more with the
organization.
Yeah, the organization, yeah.
Because, you know, when we talk about it, when we used to think about, you know, so evidence-based practice is what's instilled in all of us as clinicians that we should do. And then quality improvement initiatives really were also for a long time led by clinicians. And then, and still is. And then you have then the inclusion of families and patients in that research and quality improvement, but often the stakeholders that we always wanted at the tables, but not necessarily there, were executive leadership, or how did you get it on the agenda from a organization point of view, right? But when as soon as you start with things like organizational, optimal running organizations, and systems learning is almost like a business model. So that sort of, I think, lends itself to potentially a broader, greater uptake, I think, because then the people who are likely to provide the resources are the people who are actually driving it. Organizational performance and stuff. Anyway, that's just how I in my mind, sometimes that's how I'm trying to think of it, but I still haven't made my final decision on that. But
no, it's a really helpful conceptualization, and yeah, it's getting me thinking too. Thanks, Marcia.
We have just a couple more minutes. Go ahead, Logan.
Yeah, I think at the end of the day, I agree with you there, Marcia. I think like having a little bit more experience in the system side now and out of the research world, like it's important to engage those stakeholders. And if it is researchers driving, you know, whether it's like quality improvement, knowledge translation, patient-oriented research, like that's still coming from outside of like the nexus of power or decision making. So I think that you're right that learning health systems is almost like a business model, and that it's a way to sell this package of ideas to health system decision makers in a way that makes them accountable for it. So researchers are still a part of studying change and figuring out, you know, from an implementation science perspective, how do we make this change happen? But the learning health system allows the health system some accountability to say, okay, this is what we're going to want to do. It's a bunch of different things, but this is what we're trying to achieve. Not just, you know, the triple aim or the quadruple aim. It's more than just the outcomes. It's what's the process we're taking as well.
Well, and I actually think too, like if you think about it, some of the biggest challenges with uptake and sustainability with patient-oriented research is, family engagement. You have the researchers, maybe a few clinicians, but overall, often it's the clinicians or the clinical is the place where it stops, or it stops happening because it reverts to the next priority and care. But if it's from the organizational level, I feel that people will have less of an option to say, oh, that's research, it's not really my job, or okay, that study's over, I can move on to the next thing, versus if this is ingrained as an organizational philosophy and expectation to work there. I don't know. That's how I sort of think that maybe we've kind of moved towards thinking maybe we'll have some success with sustainable change.
Okay, well, we have 1 minute left, and I want to say thank you so much, Christine and Mari, for a wonderful presentation and really excellent discussion from the audience. So appreciate everyone being here, and enjoy the rest of your day.